Hello. I'm going to talk today about another very significant paper. We were waiting for such a long time, and it was published in a research report in this February, so a few days ago. So the team is coming from famous Ioannidis laboratory, and the first author is Leichenring et al. They did a perfect job of applying open science rules, especially PRISMA rules for meta-analytic review studies, on efficacy of psychotherapies and pharmacotherapies in mental disorders in adults. For me, it was really a celebration of something that people were trying to talk quietly some time ago, because once they put a rigorous statistical testing with meta-analytic controls for biases and other things, they really find out that across different mental disorders, one of which is most interesting for me, for my research, depression, also is in line with this, that actually across disorders and treatments, the majority of effect sizes for target symptoms were very small. If you compare the literature, you usually have randomized controlled trials. But when you get a little bit closer and see how they did it, how the authors performed this study in comparison, they mixed the data between waiting lists and really some factors, therapy as usual and placebo. But let's try to just get the essence of this paper. Leichenring and colleagues actually collected a big numbers of studies published in psychiatric journals, medical journals, etc. They started with more than 23,000 of studies found, and when applying their exclusion criteria, they ended up with 102 studies in total to compare. And with this, actually, they covered many studies. To be precise, 3,782 studies, which were reporting on randomized control trials, whether about effectivity of some antidepressant treatment or psychotherapy treatment, or comparison between pharmaco and psychotherapy, or combination of pharmacotreatment and psychotherapy. Why this is important? Because the first choice in mental disorder today in current psychiatric practice is either pharmacotherapy or psychotherapy or both. They wanted to see whether what every psychiatrist who is treating patients for mental disorders, from depression to schizophrenia, post-traumatic stress disorder, anxiety and other psychiatric disorders, whether that is justified with the reports from last 50 years of research. They started from looking at one meta-analytic study, which is published in 2014, which actually reported that pharmacotherapy and psychotherapy, together or apart, actually have, according to the Cohen's d, effect size, which is medium, meaning 0.5. But if you are controlling for biases in all those research, the picture is quite different. So they actually collected the studies from 2014, ending with last year, 2021, and they collected, actually in the end, they included 102 studies. That cohort actually enrolled 650,514 patients. There are different kinds of studies. Some of them were reporting about effectivity of antidepressant drugs. Some of them reported only on effectivity of psychotherapy. Some of them confronted psychotherapy with antidepressant treatment outcome, and some of them actually used the combination. So this study, published by Leichenring and co-authors this year, denounced the result of previous study from 2014, which were claiming that there is medium-sized effects. It is not so. To cut things short, because my research is basically focused on detection of depression, innovative therapies, and prediction. I actually focus on the part of the results that they're reporting on the depression. We actually find that standardized mean value is across all publications, which were review studies on effectivity of any treatment used in depressive, is small, 0.31, and when adjusted to biases in comparison to treatment as usual, this is really small effect size. The only exception in all cohorts of all these studies included was one study when ketamine was used, and this has really a large effect size. All effect sizes with standardized mean achieved by pharmacotherapy in comparison to placebo were below 0.5, ranging from 0.19 to 0.40. And the exception was ketamine, which achieved large short-term effects, 0.83 to 0.88, confidence interval included, 24 hours and 3 to 4 days after the treatment, dropping to 0.31 after 7 days. So, in general, when we are talking about depression, among other disorders the authors actually examined, the mean response rate for selective serotonin reuptake inhibitors was 51% versus 39% for placebo, corresponding to small effect size. Then many trials of pharmacotherapy in depression showed a high risk bias. So when we look closer to the studies included, we can see that some of them, as review studies, did a review only of 2 or 3 previous research. They were biased in the methodology, how it was used. For example, some authors, when reporting about other previous studies, just averaged the effect sizes. They didn't apply recommended procedure how we calculate for randomized effect sizes. Also, they didn't correct for biases because, for example, whenever you find the result that either pharmacotherapy or psychotherapy was having medium effect size, when you correct for biases, it turns out that in the end, very small effect size. When they were discussing the results, there are few exceptions. For example, they find out that psychotherapy is working with medium and sometimes even large effect size in obsessive-compulsive disorder, and also medium and large effect sizes were found in psychotherapy treatment from post-traumatic stress disorder. But in general, what is also important to note here, for example, first thing, serotonin reuptake drugs, which are very often used as first choice of drugs when a patient has depression, actually didn't demonstrate across all these studies to have more than very, very small effect size, sometimes even 0.11. This is in accordance with STAR-D study published in 2017. This is a large collaborative study which had different aims, but exactly their conclusion from 2017 is in line with this publication, because they said that antidepressant drugs are effective between 0.11 to 0.27% of the cases, which is really low. Since I already told you about overall results, I just want to extract some small pieces of the text which are very important because the authors were brilliant in how they describe their results. For example, in bipolar disorder, for psychotherapy of bipolar disorder, the largest meta-analysis reported a small effect size in comparison to treatment as usual, with the small effect sizes for both depression and mania symptoms, and for relapse prevention post-therapy. It is interesting to find out here because lithium is believed to have really good effects in prevention of mania, but they say small effect sizes for the prevention of any mood episode were achieved by lithium and several other drugs. Earlier meta-analysis reported heterogeneous results for the prevention of any relapse by lithium. To conclude, effect sizes were very small. Small effect sizes were found for antidepressants as well in bipolar disorder. So another important result of this perfectly, brilliantly performed meta-analytic study is that when you compare the effects of psychotherapy and pharmacotherapy across many mental disorders they analyzed within this project, there is actually not any significant difference. They both have small sizes. For example, they say that head-to-head comparison of psychotherapies versus pharmacotherapies yielded small effect sizes for all disorders examined: depressive disorders, anxiety disorders, PTSD, and OCD. And this boils down that actually they say that when you compare psychotherapy with pharmacotherapy, standardized medium was 0.32 for pharmacotherapies and 0.36 for psychotherapy. So neither of them actually have a large effect. To conclude, discussion says that this is something really wrong in the current treatment of mental health disorders, because they also mentioned one of very interesting publications from several years ago, which is named $1 Trillion Brain Drain: Enormous Costs of Mental Health Problems in Europe Not Matched by Research Investment. So the thing is here that when you think through all those results, and I will repeat, author says, we found small benefits overall for both types of interventions with an average standardized mean difference of 0.35 and moderate heterogeneity across conditions. There is an additional gain of psychotherapy and pharmacotherapy in the treatment of mental disorders in adults, but this is small in terms of effect sizes. Conditions for which very extensive evidence was available almost always had such modest effect sizes when only studies with low risk of bias were considered or efforts were made to correct for bias. The only thing which jumped out with effectivity in depression treatment is actually ketamine, which had large effect sizes, 0.86 to 0.88, 24 hours to 3 to 4 days after the intake, but within the week those effect sizes are falling to the average small effect sizes like other medication use. So among conclusions, authors say that this should not be seen as a nihilistic or dismissive conclusion, since undoubtedly some patients do benefit from the available treatments. However, realistically facing the situation is a prerequisite for improvement. Pretending that everything is fine will not move the field forward. And it immediately comes to my mind one book published in Netherlands by Professor Jim van Os, We zijn niet goed. In translation, we are not well. This boils down to the conclusion of several suggestions how we can improve the situations. First from all, we should practice open science rules, because this is one of the big red flags that something is wrong in reporting and doing science, and those trillions of dollars wasted on this kind of research, which are not reported accurately without bias, are actually close to no use to people who are working in real world with real world patients, because when you try to apply research in real life situations, you can find out that practical situations are very often more complex, because majority of people have more than one mental disorder, and treating them for one single thing with one single neurotransmitter, do you even think that it is a good idea anymore? After 50 years of research and throwing so much money on this kind of justifying the current practice in psychiatry, it basically came to an end. The authors concluded a paradigm shift in research seems to be required to achieve further progress. Indeed, I'm very excited about this publication and the previous one about biased publishing about the effectivity of antidepressants, and I really hope that it will switch tide to the open-minded approaching of the problems that we have and letting innovations in psychiatry. Thank you for listening.